You know that feeling when you walk onto the unit at 0700 and before you've even had your coffee, the board is just lit up like a Christmas tree.
Hmm.
You've got alarms from 3 different rooms, your SpectraLink is buzzing with a pharmacy alert, and now, here in 2026, you probably have a predictive model on your tablet flashing some red probability score for a patient who, frankly, looks perfectly fine.
It's the modern fog of war, but, in a hospital
It's not even
corridor.
a fog anymore, it's a storm, a data storm. And that is exactly where we are starting today.
Yeah.
We're looking at a presentation that, honestly, it kind of terrified me, but it also made me feel seen. We're diving into the work of Timothy Simpson. He is a CCRN and a stat nurse at Baycare Winter Haven Hospital.
And for those who might not know, a stat nurse isn't just any bedside nurse. Simpson describes his own role as a force multiplier, gap filler.
A rapid response asset.
Exactly. He's the person who runs toward the fire when the systems, whether they're human or digital, start to fail.
Which gives him this really specific vantage point. He's been in critical care and administration for over 22 years. So he has seen the transition from, paper charts to the digital overload we have now.
Right.
And his central argument is something that just hits hard. He says that in 2026, data literacy isn't a nice to have skill for the tech geeks in informatics. It is a survival mechanism for every single nurse on the floor.
It's a pretty bold claim,
Yeah.
but looking at his evidence, it's really hard to argue against it. He's essentially saying that we've built a healthcare system that generates more information than our workforce is currently trained to process.
Right. And that's the tension I really want to explore today. I'm coming at this from the clinician's perspective, the one who has to actually use this stuff while, trying to keep a patient alive.
And I'll take the education angle. Because if Simpson is right, and I really think he is, then our current model of nursing education is fundamentally broken. We are training nurses for a healthcare environment that, frankly, ceased to exist about 10 years ago.
Okay, so let's get into the reality on the ground first. Simpson uses this phrase that I love: predictive pathways meet real-time chaos. That is just poetry to me.
It captures the conflict perfectly. On one side, you have the algorithm. It's clean, it's logical, based on probabilities. And on the other, you have the patient.
Messy.
Messy, unpredictable, maybe crashing for a reason the algorithm just can't see.
And the nurse is standing right in the middle of all of it.
Mm.
But here is the problem Simpson identifies: the noise. It's not just vital signs anymore. He lists the inputs nurses are dealing with now: EHRs, predictive analytics, AI models, genomics, imaging.
Mhm.
And then he throws in some terms that, honestly, I think a lot of nurses would just gloss over: de-identified cohorts and real-world evidence generation.
We should probably pause on those because they really matter. When he talks about de-identified cohorts, he's talking about how modern systems compare your specific patient to thousands of others in real time. So the computer isn't just looking at Mrs. Jones's blood pressure. It's looking at, say, 50,000 other women with her genomic markers who had a similar drop in pressure, and it's predicting an outcome based on that entire cohort.
Which is incredible technology. But if I'm the nurse and I don't understand that that is what the machine is doing,
Yeah.
what happens? I just see a number. I just see a risk score of 85%.
Exactly, and real-world evidence generation is the other side of that coin. Everything you document, every intervention, every med pass, it all feeds back into that system to train the next model.
So nurses are constantly generating the evidence that will dictate future care.
Yes.
But we aren't taught to think like that. We're taught to document for what? Billing? Or legal protection. We aren't taught that we are actively feeding a learning machine.
And that disconnect creates what Simpson calls illiteracy consequences. This is where it gets really dangerous. He lists them out: missed insights, unsafe application, and biases.
Missed insights is the one that keeps me up at night. Because the data is there. The machine might be screaming, quietly in some submenu that this patient is trending towards sepsis.
Right.
But if I don't know how to query that trend, or if I'm just treating the alert as spam, click ignore, then I miss the window to act.
The alert fatigue weaponized by ignorance. But unsafe application is just as bad. That's when you trust the machine blindly. The model says discharge ready, so you stop monitoring as closely, even though your clinical gut is screaming that they look pale.
Simpson calls the nurse the bridge between the bedside and the big data. But a bridge has to be solid on both ends. If I'm solid on the patient care, but I'm shaky on the data science, that bridge collapses.
And right now, that bridge is shaking. Simpson points out that traditional nursing programs, they emphasize clinical skills, which obviously are non-negotiable. You have to know how to start an IV.
Of course.
But there is a limited focus on data interpretation, analysis, and visualization.
Limited focus is a very polite way of saying it's virtually non-existent in a lot of places. I remember my informatics training. It was basically, here's how to log into Epic without getting locked out.
Yeah.
It wasn't, here's how to analyze a population health trend on your unit.
And that's the structural deficit. Simpson notes that even continuing education, the CE credits you scramble to get every renewal cycle, they're failing here too. They almost always skip the data science basics. So you have a workforce that is highly skilled clinically, but they're operating black box technology they don't understand.
Which leads to what Simpson calls the confidence crisis. And I feel this. When a doctor challenges you or a family member asks why the computer says one thing and you're doing another, if you don't understand the data, you back down. You lose your voice.
And when a nurse loses their voice, patient safety is compromised. Simpson is very clear. We need evidence-based decisions, not just intuition-based decisions. Intuition is great, but intuition backed by data is bulletproof.
He gives some examples of where this applies. LOS reduction MANT, length of stay, and sepsis optimization. Let's play that out. Sepsis is all about time.
Right. It's all about time.
So if I'm a data literate nurse, I'm not just waiting for the patient to spike a fever. I'm looking at the predictive trend line. I'm seeing the white count creeping up alongside a subtle shift in heart rate variability that the AI picked up 3 hours ago. I can go to the provider and say, look at this trajectory. We need to start fluids now. That saves days of ICU time. That saves lives.
But to do that, you have to know how to read the trajectory. You have to know that the AI isn't just, hallucinating. You have to be able to validate the data.
So we know the problem. The water is rising, and we're trying to bail it out with a teaspoon. What's Simpson's plan? Because he's a stat nurse, he's all about fixing the immediate problem.
He is, but his solution is actually more of a long-term infrastructure project. He's calling for total integration, data literacy as a core competency in all entry-level curricula.
So alongside anatomy and physiology, you've got Data Science 101.
Essentially. And not just as some theory class where you read about what an algorithm is. He wants hands-on training. He lists 3 specific skills that every nurse needs to have: query tools, bias detection, and data visualization.
Okay, let's break these down because this is the real meat of it. Query tools. When I hear that, I think of coding. I think of SQL. Is he expecting nurses to become programmers?
No, and that's a common misconception. He's not asking you to write code. He's asking you to know how to interrogate the system.
Interrogate it.
Yeah. Think about it this way. You're on a med-surg unit. You notice that a lot of post-op patients from, say, Dr. Smith are developing urinary retention.
Okay. A standard nursing observation.
Right. The old way to handle that is to, complain in the break room, maybe file an incident report if it gets really bad. The query tool way is to go into the dashboard, set a filter for Dr. Smith's patients, filter for urinary retention, and pull the data for the last 6 months. And suddenly, you aren't just complaining, you have a graph showing a 20% spike. That is a query.
That shifts the power dynamic completely. You aren't coming with an anecdote, you're coming with evidence.
Precisely. You become a researcher right there at the bedside.
Okay, next one, bias detection. This feels huge, especially with AI.
This is the ethical firewall. We know that AI models are trained on historical data, and historical healthcare data is just full of historical biases, racial, socioeconomic, gender-based.
Right, like how we learned pulse oximeters weren't as accurate on darker skin tones. If you feed that bad data into an AI, the AI learns that darker skin tones naturally have lower oxygenation.
Which is just false.
Completely false.
Exactly. So now, imagine an AI model for discharge planning that was trained on a wealthy suburban population. It might predict that a patient is safe to go home because their vitals are stable. But it doesn't account for the fact that the specific patient lives in a food desert with no transportation.
So the data literate nurse has to look at that safe to discharge green checkmark and say, wait a minute, I know this model is biased toward physiological data and it ignores social determinants. I am overwriting this.
That is the force multiplier effect Simpson talks about. The nurse catches the blind spot of the machine. But you can only catch the blind spot if you know it exists. If you think the computer is magic, you send that patient home, and they bounce right back in 3 days.
That is terrifying. It really puts the responsibility on us to be the skeptics.
Healthy skeptics. Skeptics with skills.
And the third one, data visualization. Again, sounds kind of fancy. Sounds like making PowerPoint slides.
It does sound corporate, but in a clinical setting, visualization is all about speed. Simpson works in rapid response. When a patient is crashing, You don't have time to read a spreadsheet of hourly vitals.
No, you need to see the trend line.
You need to see the spark line on the monitor going down.
Right.
But it's getting more complex than that. Nurses need to be able to look at a multivariable dashboard, labs, vitals, meds, and instantly synthesize that into a story. The kidneys are failing because the pressure dropped 4 hours ago. That is data visualization literacy. It's converting pixels into clinical action in seconds.
So it's the difference between reading a paragraph describing a roadmap and just looking at the map.
Perfect analogy. And Simpson argues that if we give nurses these skills, querying, bias checking, visualization, we transform them from passive data entry clerks into active leaders. Data-driven healthcare transformation, he calls it.
I like the sound of that, but I have to play devil's advocate for a second. Nurses are already burned out. We are short-staffed. We're tired. Now you're telling me I have to learn how to analyze population cohorts. Is this just one more thing on the pile?
That is the pushback I expect to hear. And it's valid, but I think Simpson would argue that this isn't one more thing. This is the only thing that makes the other things manageable.
How so?
Because the data noise is already there. It's already screaming at you. Ignoring it is stressful. Misinterpreting it causes errors, which causes more work codes, readmissions, longer stays. Learning to master the data actually reduces the chaos. It turns the noise into a signal.
So it's an investment. You learn the skill to stop from drowning?
And to survive professionally. Simpson is pretty blunt about this. He says, quote, "Data literacy isn't optional. It's survival in 2026 plus healthcare."
Survival is a strong word.
But is it wrong? Think about that black box concept we touched on. As AI takes over more of the diagnostic and predictive work, the clinician who can't understand why the AI is making a decision, they become obsolete, or worse, dangerous.
That's the whole human-in-the-loop argument. We keep saying we need a human in the loop to keep AI safe, but if the human doesn't understand the loop...
Then they aren't a safeguard. They're just a rubber stamp. And hospitals won't pay for a rubber stamp forever. If you want to remain essential, if you want to be that force multiplier, you have to own the data.
You know, it reminds me of when we first switched from paper charting to computers. There were nurses who said, "I'm not a typist, I'm a nurse," and they struggled. Some even left the profession.
I remember that.
Simpson is saying, this is the next shift. I'm not a data analyst, I'm a nurse. This ain't going to cut it anymore.
A data analyst is now part of the definition of nurse. That's the new reality.
But what about the patient in all of this? We've talked a lot about the nurse and the system. Does Mrs. Jones in bed 4 actually care if I can run a query?
She cares if it saves her life. She cares if it prevents a medication error because you noticed a pattern the pharmacy system missed. She cares if you catch a bias in the algorithm that would have denied her proper pain medication.
That's true. It always comes back to safety. Simpson mentions CMS compliance, too, which is, the boring administrative side. But compliance is usually just a proxy for, did we not kill anyone?
Right. Ethical, safe use of large-scale data. That's the bottom line. You cannot practice ethically in 2026 if you are data illiterate. You just can't. Because you're wielding these incredibly powerful tools that you don't fully understand.
It's like operating a ventilator without knowing how the pressure settings work. You might get lucky or you might blow a lung.
And Simpson is saying, let's stop relying on luck. Let's build the training so every nurse knows the settings.
So, practically speaking, for the listeners, whether they're bedside nurses, managers, or educators, what is the immediate takeaway? If I'm a nurse manager listening to this, what do I do tomorrow?
You look at your unit education plan. Is it just, here is how the new IV pump works? Or is it, let's look at our unit's data dashboard and talk about what these trends mean? Start asking your nurses, what does this predictive score actually tell us?
Make it part of the huddle.
Exactly. Normalize the conversation.
Yeah.
Don't let the data stay hidden in the background.
And for the individual nurse, the one who feels completely overwhelmed.
Start by just being curious. When an alert pops up, don't just dismiss it. Click the More Info button. Ask why. Why did the model flag this? What data point triggered it? Just that simple act of questioning starts to build the muscle.
It shifts you from being passive to active.
And advocate for yourself. If your hospital offers CE on informatics or data visualization, take it. Don't wait for it to be mandatory. Be the force multiplier.
Thrive in the data era. That was Simpson's closing sentiment. Not just survive, but thrive.
It's an optimistic view, really. He believes that if nurses embrace this, they will be more powerful than ever. They'll have the clinical touch and the digital evidence. And that is a formidable combination.
It really is. It changes the image of nursing from caregiver to, clinical engineer.
Yeah.
You still hold the patient's hand, but you also hold the data.
And that is the nurse of 2026.
You know, this whole deep dive has been a bit of a wake-up call for me. I think I've been guilty of seeing the technology as an intrusion, something that gets in the way of real nursing.
We all have, I think.
But Simpson just flips that script. The technology is the nursing now, or at least it's the nervous system of nursing. And if we ignore it, we're basically paralyzing ourselves.
And leaving our patients vulnerable to that black box.
That's the thought I want to leave everyone with, that image of the black box. We are the ones feeding it. We are the ones acting on what comes out of it. If we don't bother to learn what happens inside it, we are surrendering our professional judgment to a line of code written by someone who has never touched a patient.
And that is a risk we simply cannot take.
Timothy Simpson's message is loud and clear. Get literate, get curious, and get involved. Because the data isn't going away, it's only going to get louder.
So we better learn how to conduct the orchestra.
Exactly. Right, that is it for this deep dive. Huge thanks to Timothy Simpson for the source material. It's a provocative, necessary kick in the pants for the profession.
Absolutely. A survival guide for the modern age.
Thanks for listening. Go have some questions of your dashboard today. See what it tells you. We'll see you on the next one.
Stay safe, everyone.